today's iFocus lecture 57. Today we have Dr. Bhaskar Srinivasan, who will be speaking to us on seasonal, allergic, vernal and infectious conjunctivitis. He has done his MBBS from Mumbai University and MS from Armed Forces Medical College, Pune. He has done his cornea and external disease fellowship from Nethralaya and is also currently working as a consultant in cornea services there itself. He has various publications in peer-reviewed journals and participated in various conferences nationally and internationally. He is known for his great academic interest. We are fortunate to have you with us today, sir. Welcome and please take over.
Good evening, everyone. Thank you, Harika, and I would like to thank Dr. Honavar for giving me the opportunity. So we'll try to cover the allergic conjunctivitis and infective conjunctivitis in the time frame that we have. Can I share my screen? 1 second here. Is it seen?
Yes, sir.
So basically, we'll be covering allergic conjunctivitis first, and then followed by the infectious conjunctivitis. No financial disclosures. This is the broad outline which you will also need to remember when you're writing an answer with respect to allergic conjunctivitis as such. And at the end, we'll just go through certain interesting cases so that it gives you some practical tips in how we decide on the medications that we would want to use in these patients. So allergic eye disease is a common condition in clinical practice, and it seems to be on an increase more because of the pollution that we are exposed to, the exposure to pets, the early childhood exposure to pollution, and there seems to be a genetic basis, even though it's not very clear. It is generally bilateral, and it's mostly self-limiting unless you have the VKC kind of a disease, which can progress, but even that to a large extent stops during puberty, during 15-20 years of age. Generally, it occurs in people who are sensitized to the particular allergen. And if you look at studies, they say that approximately 20% of the population has some sort of allergic conjunctivitis. And if you look at a subset of allergic rhinitis patient, almost 60% of them have coexistent allergic conjunctivitis. So when you look at classification of allergic eye disease, you basically have the seasonal allergic conjunctivitis, the perennial allergic conjunctivitis, the vernal, and the atopic keratoconjunctivitis. The GPC is now more or less considered as a foreign body kind of a reaction, doesn't directly come under the classical allergic disease concept as such. Contact dermatitis, yes, also is basically more of a toxicity to topical medications or use. So we'll be concentrating on the first four in our talk today. Seasonal and perennial are basically the same, except for the fact that one is occurring only in a particular season and one is occurring throughout the year. The probable cause could basically be that if you're allergic to a pollen, which is more specific to a season, then you might probably have a seasonal response as far as the allergy is concerned. And whereas if you are allergic to say something like dust mite, which is there throughout the year, 365 days of the year, you might have allergic manifestations throughout the year. So generally about 20% of population is affected, and primarily it is an IgE mediated hypersensitivity where the allergen binds to the IgE bound mast cell and triggers the mast cell to release the mediators, and these mediators initiate the allergic response. The classical feature in any allergic disease is itching. So in SAC and PAC, you have a lot of itching, you have redness, you have chemosis or swelling of the conjunctiva, as seen in the picture here. So if you are looking at the pathophysiology of the SAC or PAC, this diagram actually gives you a very good idea about what happens. You have the antigens which bind to the mast cell, and once the mast cell gets stimulated, you have preformed mediators, which are basically of which histamine plays the most important role, which then causes the itching, the chemosis, the redness, and the mucosal secretions. You also have the binding, triggering formation of new molecules, which are basically more with respect to the prostaglandin family, and they also again cause the itching, redness, tearing, mucus secretion. They also stimulate the nerve, which is why sometimes they might have a bit of a pain. And then you have the chemokines and the cytokines, which self-perpetuate the allergic response. So they not only cause the inflammation, but they then act as mediators, getting the inflammatory cells into the conjunctiva to perpetuate the inflammation. When you're looking at vernal keratoconjunctivitis, again, it is a chronic bilateral disease. It's supposed to be seasonal, but it can be perennial again. The most important thing in VKC is primarily the pediatric age group is affected, and most of the times the disease subsides by puberty. But you have cases where it persists even in adult. You can have chronic disease with acute exacerbations which might need to be treated. You also have a subset of an adult onset VKC like disease, which seems to be having more of tarsal conjunctival changes and less of corneal changes. If you come to the types of VKC, you could either have it as a tarsal form, where basically most of the features are the tarsal conjunctiva showing the papillary changes. You could have a bulbar form where you have primarily limbal papillae, and you can have perilimbal pigmentation around the limbus, or you can have a mixed form where you have coexistent tarsal and bulbar papillae. Coming to epidemiology, the study by Sangwan et al. In 2013 said that the mean presentation in India was around 12 years, and about 72% patients had a mixed VKC, and almost about 35 to 40% patients, the disease was chronic and perennial in nature. Unlike published studies from Western countries, the history of allergy in our population seemed to be much lesser. And in about 12% patients, the disease persisted beyond 20 years of age. When you look at a more recent publication from the same group in 2019, they've noted a prevalence of around 10% of all children and adolescents seen in that center. It's more in summer, and the palpable form was the most common in the study that they have seen. And there is a definite male preponderance. Coming to etiopathogenesis, you basically have environmental factors, which could be either in terms of ultraviolet light, wind, pollen, and these cause conjunctival hyperreactivity and exacerbate the inflammation. You do have immunological factors, which could either be an IgE mediated or a non-IgE mediated. Unlike a seasonal allergic conjunctivitis or a perennial allergic conjunctivitis, VKC etiopathogenesis is much more than just an IgE mediated response. You can also have systemic allergies which can coexist either in the form of asthma, hay fever, or eczema. There could be a genetic or a family history, even though genetic diagnosis is still not made as a confirmatory test at this point of time. If you're looking at the predominant cells involved, you're basically looking at the eosinophils, the mast cells, the basophils, and the macrophages, which play a primary role in initiating and propagating the vernal keratoconjunctivitis inflammatory cascade, of which in the acute phase, the eosinophils play the most important role. If you're looking at a T cell response, you're basically looking at a T helper cell, which gives a specific Th2 type of cytokine profile, which basically means an interleukin 4 and interleukin 5 are increased. And this Th2 response actually increases the IgE level. So it kind of perpetuates the cycle of inflammation. So it is both an IgE mediated and a T cell mediated response, unlike the SAC or a PAC, which is primarily only an IgE mediated disease. So if you're looking at clinical features, the most important clinical feature as far as any allergic eye disease is concerned is the presence of itching. It's almost never that you will find a patient with an allergic eye disease who says he doesn't have an itching in the eye. So that's the most important symptom that you're looking at. Apart from that, you have redness, watering, foreign body sensation, photophobia, the drooping of lids if the papillae is large, and you have a ropey discharge. Again, the ropey discharge is something which is specific for a VKC because the discharge gets stuck between the papillae, and that's why the mucus discharge becomes a little bit thicker. If you're looking at the clinical signs, you will look at papillae, which could either be at the tarsal conjunctiva or the limbal conjunctiva. You could have the Horner-Trantas spots. I'll come to that later. You can have perilimbal pigmentation, and you can have features of corneal changes with respect to superficial punctate keratitis. And obviously, you can have complications of the disease and complications of the medical measures that are done to treat the disease with respect to using steroids, which can cause cataract and glaucoma, which you need to be aware of. So coming to tarsal papillae, when you're looking at the tarsal papillae, you need to look at the size of the papillae. So if you have a papillae less than 0.3, it's probably a grade 1 papillae. If it's between 0.4 to 1, it's a grade 2 papillae. And if it's more than 1 mm, it's a grade 3 papillae. Clinically, it doesn't make a huge difference, but when you're writing your answer, knowing the classifications is important. Histologically, basically the papillae are hypoplastic conjunctival epithelium with a fibrovascular core. And the presence of a papillae and a follicle is something that you need to differentiate. A papillae will have a fibrovascular tissue in the center, whereas a follicle will have a vascular core at the boundary of the elevated lesion. Multiple confluent papillae can become confluent together, giving rise to what we call as a cobblestone papillae, as seen in the grade 3 papillae here. And you can sometimes have pseudomembrane stuck on the papillae, which is called as a Maxwellian sign. When you have epithelial stippling, when you stain with fluorescein and you see the stippling on the surface of the papillae, it does indicate some amount of activity, just like the stippling which happens at the limbal papillae, which is called as the Horner-Trantas dots, which we say indicates active vernal keratoconjunctivitis. So if you're looking at the limbal papillae, it could either be at a small area, or it could involve 360 degrees. It could be gelatinous and confluent when it is called as pseudogerontoxon. And like I said, Horner-Trantas spots are these small whitish excrescences seen at the limbus. Basically, they are eosinophils along with the desquamated epithelial cells. Perilimbal pigmentation also is seen very commonly in VKC, which we reported way back in 2004. And these are basically because of the melanocytes present in the dendritic cells. Coming to the corneal involvement, Buckley et al. Described the corneal involvement in VKC as having a punctate erosion, progressing to coarse epitheliopathy, and progressing to macro erosions as such. So when you're looking at a VKC patient, you need to classify them, and you have two classifications here. One which was given by Bonanni et al. And one by Dr. Nikhil Gokhale from India. So if you're looking at Bonanni's classification, it grades the VKC from a grade 0 to a grade 5. A grade 0 is a quiescent phase disease. A grade 5 is an end stage where it has scarred. So grade 1 and grade 2 basically is going to be very mild symptoms with mild papillary reaction, no changes in the cornea, no Horner-Trantas dots. A grade 2B, you might have occasional superficial punctate lesions coming up in the cornea. But what you are going to be looking at is a grade 3 and a grade 4, where your Horner-Trantas dots will increase and your corneal SPKs will increase. So when you're having significant corneal changes or you're having significant Horner-Trantas dots, it falls into grade 3 or grade 4. And then you would need to treat the patient a lot more aggressively. So we'll come to the treatment algorithm later on, but this is something that you need to be aware of because you will need to answer this in your exam. The other way of classifying is what Dr. Gokhale has published in IJO in 2016, where he's classified it as mild. He's classified it in moderate. He has divided it into intermittent and chronic, because we do know that the disease can be chronic or it can be intermittent. And then you have the severe and the blinding forms. So the blinding forms basically are where you have the shield ulcer or the limbal deficiency. All the others with significant corneal changes fall into the severe form. If you have large cobblestones, which will form into the moderate chronic disease without having more than 6 clock hours of annular limbal involvement, falls in the moderate chronic stage. So you need to be aware that a mild form, you are only having symptoms with minimal papillae. A moderate intermittent has minimal papillae, has mild Horner-Trantas dots here, but the focal limbal inflammation is limited to less than 6 clock hours. If the limbal involvement or the cobblestones are significant, it goes into the moderate chronic form. If the limbal involvement is more than 6 clock hours and there are features of limbal deficiency, macro erosion, shield ulcer, it forms into the severe and then into the blinding category. When you're looking at complications, obviously shield ulcer is one of the most important complication which you need to be aware of. Keratoconus, because these patients tend to keep rubbing their eyes, so the incidence of keratoconus is much higher in patients with allergic eye disease as compared to the normal population. A chronic repeated ocular inflammation can lead to limbal stem cell deficiency. A large papillae in the upper tarsal conjunctiva can lead to a pseudotosis. And obviously, like we said, complications of the treatment with steroids in the form of either cataract or glaucoma will need to be looked at and treated accordingly. So coming to shield ulcer, it's basically an oval or a pentagonal shaped ulcer. It's superficial, located superiorly near the visual axis, and is an epithelial defect with an elevated margins. Now, why are we worried about the shield ulcer? Is basically because it's very close to the visual axis, and if it's not treated promptly, it will leave behind a corneal scar. Because of the presence of the epithelial defect, you can expect even a superadded infective keratitis, and a scar due to either the shield ulcer itself or secondary to an infective keratitis would ultimately lead to a decrease in vision, which is something that you want to avoid. So this is a figure depicting Cameroon's grading of the shield ulcer. And why do you need to know the grading? Is basically because the grading decides what is the treatment that you're going to be giving. If you just have a defect and the base is clear, it's a grade 1 shield ulcer. If you have a defect but the base has an inflammatory debris, then it's a grade 2 shield ulcer. But if the base has an elevated plaque like this, then it's a grade 3 shield ulcer. It's important to differentiate a grade 2 from a grade 3, because once it's an elevated plaque, epithelium is not going to grow on top of it, and you will need to surgically debride this and allow the epithelium to heal. If it's a grade 1, use of a topical steroids or a bandage contact lens might work. A grade 2, topical steroids and a bandage contact lens might work. If it doesn't, it progresses to a grade 3, where you might have to do a debridement along with a contact lens or an amniotic membrane, depending on the size of the defect. So when you're looking at managing allergic conjunctivitis, you have a medical management, you have a surgical management for the complications, and desensitization I have put separately, even though it's part of medical management, because it's a separate way of addressing the problem. The non-pharmacological treatment that you would probably give the patient would be counseling, to make sure that they wear protective glasses, they avoid exposure to known factors which trigger their reaction. If they can change their place of residence or place of work and go to a place which has less episodes of allergic reaction, that could be a possibility, but it's not always feasible. Use of cold compresses is very helpful, especially to reduce the itching in the early phase, and counsel the patients that they need to reduce the eye rubbing as such. The eye rubbing exacerbates the allergic disease and also predisposes the eye to developing keratoconus as such. Coming to the pharmacological treatment, you have a gamut of agents that are available. So basically, when you're looking at a seasonal allergic conjunctivitis and perennial allergic conjunctivitis, topical antihistaminics alone would also work. You might occasionally want to use a combination of an antihistaminic along with a mast cell stabilizer. When you're looking at a vernal keratoconjunctivitis, most of the time you'll probably be using a combination of an antihistaminic with mast cell stabilizer, along with periods where you would want to use corticosteroids as such. So this in a nutshell tells you what are the options that you have. We can use topical decongestants, but their effect is very limited. Topical antihistaminics also work, but only in reducing the itching and the redness. NSAIDs have a very limited role, not often used as far as allergic eye disease is concerned. Mast cell stabilizers by themselves can be used, but you need to start them a little bit earlier, because it does take some amount of time for the mast cell stabilizer to start functioning. So if you're looking at the class of agents, vasoconstrictors would basically reduce the itching and redness. They do have a rapid onset of action, but the duration of effect is small, and there is going to be a rebound congestion after the effect wears off. Antihistaminics also will have a short duration of action, even though it's very rapid, but they do have some symptoms of dryness in the eyes. A mast cell stabilizer will give you a long-term benefit, but you need to start the medication proactively before the actual allergic process starts. A combination of mast cell stabilizer along with an antihistaminic is probably giving you the best of both, because it gives you the immediate effect of the antihistaminic properties, and the mast cell stabilizer gives you the prolonged benefit of using the anti-allergic medication. Corticosteroids, either soft or potent steroids in certain cases, still form the most important medication that you would use in severe, very severe or blinding VKC as such. Immunomodulators like cyclosporin or tacrolimus have a role if you want to get the patient off steroids or as a steroid sparing agent as such. Obviously, they have a slightly slower action as compared to steroids, but their action is a lot more sustained as compared to topical steroids. But they do have stinging or burning sensation when you instill these medications. So in a nutshell, a mast cell stabilizers, if you're starting, you need to be starting it prophylactically before the actual allergy starts. Say if you're starting it for a seasonal allergic conjunctivitis, you need to start it maybe a couple of weeks before the actual season starts. If you're looking at a dual acting agents, the three most preferred ones right now would be either olopatadine, bupropion, and L-caftidine. Bupropion, you have a 0.1, 0.2, and a 0.7. The 0.2 and the 0.7 versions are used as a single day dosage. The 0.1 is a BD dosage. The bupropion and L-caftidine are used in BD dosages. Systemic medications, you do have the use of antihistaminic systemically, the systemic steroids, cyclosporine, tacrolimus, but again, these are for blinding diseases, not oftenly used. Systemic antihistaminic doesn't help as much in VKC or in an ocular allergy as such, unless it is also coexisting with ocular rhinitis, which is allergy induced, in which case antihistaminics would work. Patients with a very high IgE levels can be considered as candidates to require to be given omalizumab. Again, this is something which is just coming up. It's not done routinely. So when you're looking at surgical treatments, you're looking at surgical treatment for giant papillae, which could be either in the form of supratarsal steroid injections, cryotherapy, or excision, or you're looking at surgical treatments for complication of shield ulcer, for complications like for shield ulcer, keratoconus, cataract, glaucoma. I'll just be focusing on the complications treatment for shield ulcer and then the treatment for papillae. Immunotherapy is primarily designed for patients who have a systemic allergic immune predisposition along with ocular allergy. The choice of the antigen is based on the skin prick test and the IgE levels. Recently, along with an injectable immunotherapy, you also have the option of sublingual immunotherapy, and it is showing reasonable results as far as published reports are concerned. So coming to the management protocol, so what's important is to know where you are grading your disease, whether it is mild, whether it's moderate, whether it is moderate chronic, whether it is severe or it's blinding. And then based on that, of all the molecules that you have, you decide on starting. So if it is mild, then you're probably not using steroids at all. If it's moderate, which basically means there is some amount of corneal involvement, there is some amount of Horner-Trantas dots, you might want to start with a pulse dose of loteprednol for a couple of days and then stop it. But if it is chronic, it's progressing it's persisting for a fairly long period of time, you might want to continue the low dose loteprednol or fluorometholone for a slightly longer period of time. If it's more severe and you're not able to get the patient off topical steroids, then you're looking at immunomodulators like cyclosporine or tacrolimus. Again, cyclosporine, what has been tried is the 2%. You do have some reports with the 0.05%, but generally for an allergic eye disease, the 0.05% doesn't work as well, and you would be looking at using the 2% cyclosporine. What works reasonably well these days is the use of tacrolimus ointment, because the tolerance of tacrolimus in the eye is much better from a patient point of view as compared to 2% cyclosporine. And if there is significant issue with papillae, or there is a shield ulcer with a plaque, then you would need to surgically debride that. The option is for cryotherapy or excision of the papillae, along with use of mitomycin or the use of conjunctival autograft, amniotic, or a buccal mucous membrane graft. But these are for very, very, very rare cases. So another simpler table would be what Leonardi et al. Has suggested, where it's very simple. You have a mild disease where there is no corneal involvement, it's only anti-allergic eye disease. Presence of symptoms with mild photophobia, you want to use a combined anti-allergic drop with a mast cell stabilizer. When you have photophobia and corneal involvement, you're using a low dose steroid. And when you have a diffuse corneal involvement, you're probably using pulsed dosage of high dose topical steroid, or you're using the systemic or topical immunomodulator, as the case may be. Coming to the giant papillae, these are the list of treatment options for the giant papillae. So once you see any disease or any condition with multiple treatment options, you need to realize that it's not that any one treatment is working in all cases. So you might have to start off with one and gradually see the response, and then take a call on what you want to do next. What has shown a reasonable amount of success in certain recalcitrant cases with giant papillary conjunctivitis is excising them along with a conjunctival autograft, as published by Paulo Dantas et al. With fairly good results. Or the other option is excising them and replacing them with the buccal mucous membrane graft, as we published a couple of years back. Coming to atopic keratoconjunctivitis, again, the features are very, very similar to vernal keratoconjunctivitis, except for the fact that generally the age is a little bit older and it doesn't stop at puberty, it tends to get worse. Again, the classification of atopic keratoconjunctivitis is a little bit controversial. In Japan, anybody with an atopy and an allergic eye disease like VKC is classified as atopic keratoconjunctivitis, whereas in Europe and US, the classification is a little bit different. So you will have papillary changes here also, but generally the papillary changes in the lower tarsal conjunctiva are much more as compared to what you would see in a classical VKC. You can have a fold of the skin in the lower lid, which is called as a Denny Morgan fold. The corneal SP case can progress to a shield ulcer, and you also have issues with conjunctival cicatrization, dry eyes, and the intraocular inflammation can give rise to a shield cataract, in addition to the posterior subcapsular cataract that can come because of the use of steroid. Treatment is with topical steroids, topical immunosuppressants, and in these patients, you might want to consider systemic steroids or systemic immunosuppressants along with the help of a dermatologist or an immunologist. So we'll go through certain case scenarios so that you are clear as to how you would use the medications. So this patient has occasional Horner-Trantas dots, cornea is reasonably clear, small papillae, so he fits into the grade 2B, and he would do well with a dual-acting medication as such. The SPKs here in the cornea are not seen because you've not put the fluorescein stain pictures, but you have larger papillae. You can see staining on the surface of the papillae, and the cornea also stained. So he's a grade 3, and here we started the patient with topical steroids and topical dual-acting agents. He was not able to we were not able to get him off topical steroids. Every time that we stopped the steroids, he had a recurrence, so we shifted him to a topical tacrolimus, and he's been stable ever since. Another patient with a grade 3 to 4 VKC, where there is a mixed pattern with both limbal and tarsal VKC. He also had keratoconus. So we controlled the disease with topical steroids and then gradually shifted him to topical immunomodulators. And once the disease is under control, he underwent a C3R for the keratoconus in one eye and a lamellar keratoplasty in the other eye. A patient with a limbal VKC with early limbal stem cell deficiency did not have any other systemic features of atopy. We managed him initially with topical steroids and then with immunomodulators, and then he was able to shift to a hilly area, a cooler place, and to that extent that significantly improved his comfort. And you can actually see how much the cornea has cleared once the inflammation has been brought under control. Another patient with a severe grade 4 VKC with a shield ulcer with papillae. We managed the shield ulcer with supratarsal steroid and an amniotic membrane transplantation. He also had coexistent allergic rhinitis and was treated with systemic inhalers with steroids off and on. And he was comfortable with that. Probably the inhalational steroids also helped in reducing the ocular allergy. Again, when any patient is on any form of steroids, you need to be careful regarding the intraocular pressure. A patient with severe grade 4 tarsal VKC with a shield ulcer was managed for the shield ulcer initially. For the tarsal papillae, we did cryotherapy. It worked only to recur. We treated him with oral steroids. Again, once the steroids stopped, the papillae recurred. And finally, we went ahead with excising the papillae and replacing it with a buccal mucous membrane graft. And for the last 2 years now, there has been no recurrence of the papillae in the area that was excised, and his eye is also quiet. This is an interesting case where you're seeing an adult with a VKC-like picture. You're seeing both a limbal papillae and a tarsal reaction. And he complained of itching for the last 8 months, on and off topical prednisolone. And when we looked at the history, he was a known HIV patient since 2013, and his CD4 counts at that time was 184. He had stopped his heart, and his recent counts were 46. Once he restarted his HART treatment, his allergy improved. And this is what we published in another case in IGO, where we said that there is something called as a TH1 to a TH2 shift. The VKC is something which is a TH2 shift. Certain other immune diseases are a TH1 shift. And this shift between from a TH1 to a TH2 phase worsens the allergic condition. So if you have an immunosuppressed state, you will need to correct that, and that also improves the allergic component. So we'll just take certain questions on allergy before we go to the next topic, because the allergic diseases were the primary focus that I gave for this particular webinar. Or you would want me to finish the infections and then we go to questions?
Sir, either way is fine. Or I think we can finish up the whole topic, sir. I'll take the questions all at the end, sir.
Okay, sure. So when you're looking at infective conjunctivitis, you're basically looking at inflamed conjunctiva, hyperemia, discharge. Viruses are the most common cause of infective infective conjunctivitis as such. And amongst the viruses, adenovirus is the most common cause that we do look at. In adenovirus, you have basically four types of conjunctivitis. You could either have an acute follicular conjunctivitis, where there is no specific serotype which causes it, but all serotypes can cause it. You have an epidemic keratoconjunctivitis, which is most commonly seen with serotype 8, 19, and 37. You have a pharyngoconjunctival fever, which is seen with serotypes 3, 4, and 7 here. In addition to conjunctivitis, the patients will have upper respiratory tract infection, soreness in their throat. And you have a chronic follicular conjunctivitis, which is more often seen with a serotype 8. So you need to know the serotypes, because it can come, epidemic keratoconjunctivitis does come as a question in your DNB or MS exams. The transmission is by droplets and fomites, and especially if you are in a crowded area, say a hospital or say a cinema theater and stuff like that, you would have a higher transmission of infection from person to person. As far as ophthalmologists are concerned, we have to be very careful when we see a patient with viral conjunctivitis, because all our equipments that we use, whether it is the tonometer, whether it's the contact lens, whether it's a slit lamp, we need to clean it once we see the patient. Also, the patient should be at our OPD for the least amount of time to reduce the risk of transmission of the infection to the other patients. Clinical features are fairly simple in terms of redness, which is generally unilateral at first and then becomes bilateral. The effect in the second eye is generally much lesser as compared to the effect in the first eye. That is, the first eye is always the worst of the two eyes. The discharge is generally watery or serosanguinous, and it is not mucoid or not a mucopurulent, which differentiates it from a bacterial or an allergic conjunctivitis. You can have associated irritation, photophobia. Presence of follicles is an important feature. Membranes, you could either have pseudomembranes, which basically are inflammatory debris, but the underlying epithelium of the conjunctiva is not affected. So these membranes peel off without any evidence of bleeding. Or you could have true membranes when the inflammation is much more severe, where the conjunctival epithelium is also peeled off. So when you try to peel these membranes, there is patches of ooze of blood from the tarsal conjunctiva. You could have lid edema and periocular lymphadenopathy. Again, periocular lymphadenopathy is more commonly seen in pharyngoconjunctival fever. When you're looking at the effect of the adenovirus on the cornea, because that is what actually causes the decrease in vision that these patients sometimes complain of, you have what we call as adenoviral keratitis. Initially, you have corneal microcysts which stain negatively with fluorescein. Then they progress to a punctate staining. They progress to a subepithelial infiltrates, and then they end up with a nummular scar. Most of the time, the corneal findings start by around the end of the first week, somewhere around the 6th day to the 15th day as such. It could either indicate an infectivity, or it could indicate an immune reaction that your body is reacting to the virus-laden cells. So if you look at this OCT image, which Dr. Nikhil has published in IJO, it shows how to differentiate an active infiltrate from a scar. So if you look at the OCT, there is below the Bowman's layer hyperreflectivity in the above image, which basically indicates an activity, but the epithelium is intact. And once it is scarred, you can actually see the Bowman's is irregular and the epithelial thickness is irregular. This is a scarred face. So if you end up seeing this kind of a face, then you know that the scar might probably remain, it might not go off. And if the patient still complains of a visual disturbances, then at some point you might have to consider surgical intervention for that. What are the differential diagnoses when you see a patient with an adenoviral keratitis? Would basically be something which is called as a microsporidial keratitis, Thygesson's keratitis, or an HSV. HSV is simple because most of the times you will be able to see a dendrite somewhere. Thygesson's and microsporidial are a little bit difficult, but the difference between microsporidial and adenovirus is the appearance of the SPKs. The SPKs are more stuck on, they are much more elevated on the epithelium as compared to an adenoviral. And if you look at the OCT, which has been published in IJO by Sridhar et al., you can actually see that the epithelium is a little bit thicker with the hyperreflectivity increasing it. And even when they end up having an anterior stromal inflammation, your epithelial thickness is still on the higher side in those areas. This differentiates it from an adenoviral infection as such. How do you treat it? Basically, the first would be to prevent transmission to others. When you're using any of these equipments, you have to clean them thoroughly before you call the next patient. Primary treatment is only supportive. There is absolutely no role of acyclovir in treating adenoviral keratitis or conjunctivitis. Ganciclovir has some debatable role. Cidofovir is known to have some beneficial effects, but it's not freely available. Recently, the use of povidone with a low dose steroids has showed a fairly good response in reducing the duration of the virus shedding and reducing the number of corneal complications in these patients. However, when you use steroids, you need to be aware of the risk benefits in that patient. And the primary role for steroids is if the vision is decreased due to corneal lesions, in the presence of severe photophobia, or if there is severe membranous conjunctivitis. The role of immunomodulators like cyclosporin or tacrolimus is if the patient becomes steroid dependent. And if the nummular scars cause a decrease in vision and you've kept the patient for a couple of months and the scars don't seem to settle down and the patient's visual quality is still hampered, you could consider a phototherapeutic keratectomy for him. The dry eye needs to be managed because if your conjunctivitis is very severe, they might end up with significant dry eyes. Coming to the next would be a bacterial conjunctivitis. The features are primarily similar except for the fact that the discharge is going to be mucopurulent. And if the organism is very virulent, you might end up having corneal involvement pretty early in the disease process. How does it happen? Basically, the host defense mechanism is disrupted either in patients with an ocular surface disease, lid abnormalities, lacrimal sac disease, or a post-surgery or a trauma, or patients with systemic immunosuppression. They are more predisposed to developing a bacterial infection of the conjunctiva. So what are the types of bacterial conjunctivitis? Would be either an acute, a hyperacute, or a chronic, and you need to be aware of the organisms which cause them because your prognosis and your treatment is going to vary. So if an acute, it's primarily a staphylococcus, streptococcus, or H influenza. A hyperacute is primarily the Neisseria, either gonorrhea or meningitis. And the chronic is again a staphylococcal, moraxella, or an enteric bacteria. If you're looking at an acute bacterial conjunctivitis, the treatment is generally very simple. You're using any broad spectrum antibiotics. The most commonly used ones would be a 4th generation fluoroquinolone as such. If you're looking at a hyperacute conjunctivitis like Neisseria, you're generally going to be looking at either neonates getting it, or you're looking at sexually active adults getting it, in which case you have to check the partner of the patient also. And the discharge is going to be much thick and greenish. And there's rapid corneal involvement if it is not treated adequately, and you will need to give systemic treatment along with topical treatment to these patients. Angular conjunctivitis, where you can have congestion, foamy discharge, irritation around the canthal areas, and this is mostly caused by moraxella, and the treatment is with a broad spectrum antibiotic, and it generally works. Coming to chlamydial conjunctivitis, again, you have 3 variations of chlamydial conjunctivitis, which could either cause a trachoma, which is basically serotypes A, B, and C, or it could be an adult inclusion conjunctivitis or a neonatal chlamydial conjunctivitis, which is seen in serotypes D to K, both of which are sexually transmitted diseases, either in the adults or with neonatal because of the passage through the birth canal. So when you're looking at trachoma, the features would be congestion, follicles, papillae, tarsal scarring, concretions, superficial punctate lesions, Herbert-Spitz, I'll show you the picture next, superficial micropanus, corneal scarring, lid abnormality, and cicatrizing conjunctivitis. Grading is something which I'm sure you all would have read about with respect to Fisto and the McKellen classification. Luckily, the incidence of trachoma is not so commonly seen, at least in India these days, though we still see patients coming in from the Middle East with features of trachoma. So this is how a classical Hubbard pit looks like. You can see the depressions at the area of the limbal follicles, which was there because of the scarring, and the classical appearance of a subtarsal scarring or the arch line. Neonatal conjunctivitis, you could either have a toxic cause in terms of silver nitrate. Again, the usage is much lesser these days, so we don't see it. The other causes would be either chlamydia, Neisseria, bacteria, or virus. Again, you need to know the time of onset, and you need to be sure about what you would want to treat them with, because some of them would require, like chlamydia would require a systemic treatment. A bacterial cause would require only a topical treatment. HSV would be a topical treatment, but a systemic treatment would be required in case there is some amount of CNS involvement. And just to complete the various types of conjunctivitis, the ligneous conjunctivitis, where you have a thick woody whitish membrane, generally bilateral, it's supposed to be due to plasminogen deficiency, tends to recur. You might see similar lesions even in the lips and the mouth and the throat of the patient. Treatment is difficult because it recurs, but there are some reports of response to topical cyclosporine and fresh frozen plasma injections and drops. Thank you, and I think I could now take questions from the audience.
Thank you so much, sir, for such an extensive presentation. I'll take the question, sir. The first question is, how rubbing causes keratoconus? We are going from allergic to infection, sir.
Yeah, basically the trauma to the epithelial cells allows the tears, inflammatory mediators to go in, and that gradually makes the stroma, because the moment your epithelium is shed off, even microtrauma, you have the tears which have the matrix metalloproteases, which gain access to the stroma. They cause stromal melting, and that kind of progresses. The epithelium plays a very important role in maintaining the entire stroma. So it's both, you have a stromal disease because your collagen is not as strong, but you have an epithelial disease with respect to allergy or eye rubbing, which aggravates your stromal weakness.
Okay, sir. The second is, what is plaque debridement and how it is done in VKC patient?
So the plaque debridement, like I showed you, was an elevated lesion, which is basically fibrin and mucoid deposit, and it sticks to the bare area of the cornea. So once it is there and it is stuck to the cornea, the epithelium will not grow on top of that inflammatory debris. So you can just use maybe a buckle knife or a crescent and shave it off the cornea. Don't go too deep, just on the surface of the cornea, you just brush it with a blunt instrument or a slightly sharp instrument like a crescent blade to peel it off. The base should be healthy, only then the epithelium will grow on top. Unless that happens, the epithelium is not going to grow there.
Okay, sir. So is any radioactive material used for that plaque debridement is called as plaque? So is it like any iodine?
No. This plaque is only the clinical description of an elevated lesion there. It has got nothing to do with a radioactive plaque as such.
Okay, sir. What is any role of giant fornicial syndrome in case of allergic conjunctivitis, and how do we diagnose it?
Giant fornix syndrome is not generally seen in allergic conjunctivitis as such. It's generally seen in older patients where the fornices are deep, and it forms one of the differential diagnoses for a chronic conjunctivitis as such. And it's more with respect to staphylococcal colonization, and the fornix is so deep that there is tear stagnation there, and there's staphylococcal colonization on the ocular surface. The tears are not able to come out, and the colonization increases. So there you might actually have to give a course of antibiotics for a slightly longer period of time. And if the fornix still doesn't settle down, you might actually have to consider some kind of surgical treatment to reduce the depth of the fornix.
And what are the clinical diagnostic features for the same, sir? Giant fornicial syndrome.
Giant fornicial syndrome is basically a very deep fornix. You've ruled out all other causes of a chronic conjunctivitis as such, and generally in a slightly older patient.
Okay, sir. The next is
the other differential there would be canaliculitis. Again, if you have an infection of the canaliculus, you can have repeated episodes of inflammation, chronic conjunctivitis going deep till the fornix and the medial canthus. and you can just press on the lacrimal sac area, and if your puncta shows up granules which are coming out, that indicates canaliculitis, in which case you will need to flush the canaliculus with antibiotic solutions on a regular basis, or do a canalicular cut down, because the actinomyces, which is most common cause for canaliculitis, doesn't get killed when it is inside in the puncta. The drops don't reach the concentration there.
Okay, sir. The next is when we are prescribing olopatadine. So, what is there any difference in the dose between the children and the adults, and how long can we use safely in both the age groups?
Yeah, so olopatadine can be fairly safely used for months. It doesn't have any side effects. As far as dosage is concerned, it initially came in a 0.1 concentration where we were supposed to use it 2 times in a day. Now, different companies have it. The Alcon has a 0.2, and now a 0.7 version is also available from a different company in India. It's available in US from Alcon for the last year or so. A 0.2 and a 0.7, the dosage is once in a day, whereas a 0.1, the dosage is 2 times in a day. Between adults and children, no issues as such, but generally adults, you would not, unless you're looking at an HIV patient or an immunosuppressed patient, you normally don't have such severe allergies that you would need to use olopatadine for fairly long periods of time. Whereas for children, you would probably want to use it because that's still safer than topical steroids, especially in a VKC patient. If you are able to maintain them asymptomatic on olopatadine, then I would probably think that would be safer than a regular once a day or alternate days of topical steroids or tacrolimus.
Okay, so the next question follows that, is there any difference in potency when we are using olopat of 0.1, 0.2, 0.7%?
There is the concentration, because the potency is basically, there are two issues with the increased concentration. One is the effect is slightly more, and because the effect is more, the company says that it lasts longer in the eye, and that is why the dosage is once in a day. But if you compare the studies which have looked at a 0.2 with olopatadine versus, say, the other and dual stel agents which are used 2 times in a day, then the patients do feel that the itching is much lesser when they use a drop which is twice in a day as compared to once in a day. So if you use olopatadine, say, only once in the morning, generally by evening they do feel a little bit of an itching. Whereas if you're using it once in the morning and once in the evening, then your itching is much better controlled.
Okay, sir. So any specific percentage of drug which you will prescribe for the children, like 0.1, 0.2, and the duration time?
I think what is now normally available is a 0.2, which is once a day dosage. You can give it twice also. It doesn't have a side effect, because even a 0.7, people are giving it twice in a day. But what the company recommends or what is published is once in a day for a 0.7. 0.7, I think in India, we have only one company which is marketed it at this point of time. But most of the time, a 0.2 works. But the fact is, if you have corneal involvement with respect to SPKs or significant Horner-Tantas dots, none of the dual-acting agents also work. You will need to give them a short course of steroids. So the dual-acting agents are primarily going to be your maintenance dose. In between, you have to give your topical steroids, or in the very mild form of the disease where you don't need to go to the steroid as such. And if you feel that you need steroids more regularly, you might want to shift to something like topical tacrolimus or topical cyclosporin, which doesn't have the side effect of steroids. And topical cyclosporin and tacrolimus, we can easily give for a 6-month period without an issue. We normally give it twice in a day in terms of tacrolimus, twice a day for about a 3-month period, and then once in a day for the next 3 months. There were concerns with lymphoma as one of the side effects or risks of long-term tacrolimus in one study, but then there was another study which has now come out conclusively saying that topical tacrolimus usage doesn't have that risk factor as such. So I don't think we need to be too worried about it. Topical cyclosporin is also good, but the problem with topical 2% cyclosporin is it is too irritating, so children generally do not tolerate it.
Okay, sir. The next is, what is Demi-Morgan fold, sir?
It's basically the lower lid. You have a fold of conjunctiva, a fold of the skin, which is parallel to the lower lid as such, which is seen in atopic keratoconjunctivitis, which has been described in that. there's no clinical significance to it, except for the fact that it's been described in the disease.
Okay, sir. So, when we are using supratarsal steroids in case of allergic conjunctivitis, what is the dose? What is the precaution, and what are complications can occur in those patients?
So you need to decide whether you are using a short-acting steroid such as say dexamethasone, or you're going to be using a long-acting steroid such as triamcinolone. Based on that, your dosage will depend. So if you're going to be using a long-acting steroid like triamcinolone, probably giving about 4 mg would be sufficient. 4 to 8 mg would be sufficient. But again, any patient that you're giving steroids, especially a long-acting steroid, you have to monitor the pressures. So if you're giving a topical, the procedure is fairly simple. You're just injecting with a 30 gauge needle around the tarsal superior tarsal plate, because that's the area where the conjunctiva is a little bit lax, and you'll be able to get a plane to inject the medication. And you will monitor the IOP for the first month to 2 months, especially if he is on, especially if you're given Tricot as an injection. And that's the problem, because if the child is too small and we are not able to monitor the pressure, then we might have to take the patient up again under anesthesia to check the pressure once, at least in about 2-week period, if we feel the child is too small to allow us to check the pressure in the OPD.
And sir, is it given in between the papilla or into the papilla? Like, what is the level where we are giving?
Right. If you flip the lid, the junction of the conjunctiva with the upper tarsus, that area the conjunctiva is lax. Over the tarsal plate, the conjunctiva is tightly bound to the tarsal plate, so you will not get a space to inject. So you just flip the lid and inject it at the upper conjunctiva, just above the tarsal plate.
Okay, sir. The next is, what is when we are doing cryotherapy for VKC, for how long that cryo is being kept there? Like for how 10 seconds, 20 seconds, or?
Generally, there is no study to say how long the cryo needs to be kept. We basically allow maybe about 8 to 10 seconds for a nice ball to form, and then we apply it to adjacent. So when you're doing a cryotherapy, individual papillae, you are applying a cryo. Unlike say when you're doing an OSS excision where you are giving a double face throw to the edges. Here, it's a single application of cryo to the papillae, and the way it works is basically we expect the blood vessels to kind of shrink, and the inflammatory cells to kind of move off, and the papillae flattens. It works for a certain period of time before the allergic process again sets in, and again you tend to form the papillae, because the papillae forms because of the histology of the tarsal conjunctiva, which has septae and it has spaces in between where you have the inflammatory cells forming. You don't see papillae in the bulbar conjunctiva. You see it only at the limbus, because there again the papillae is much more firmly adherent to the limbal area.
So, so what is the end point when we are using the cryo? Is it just the ice ball formation, or the ice ball should?
Ice ball formation, which covers the entire papillae.
Okay, so one single papillae in one go.
Yes.
Okay, sir. The next is you discussed about TH1 shift and TH2 shift. So how is it different, and is there any role of management? Management also differs when we do that, and when we ask the patient to get a TH1 level done.
No, it's not like a TH1 level. It's not something that we would ask a patient to do, because we don't, looking at cytokines on a regular patient is not something which is so easy at this point of time. The idea of just telling you that was when you have an immunosuppression, we expect that the immunity is less, and the even an allergic response should be lesser, but that it doesn't work like that. When you have HIV, which reduces your cell-mediated immunity, your humoral immunity can actually increase, and that is what is called as a TH1 to TH2 shift. Similarly, in pregnancy, you have the reverse happening, because if there is significant TH1 effect, then you will actually end up aborting the fetus as such. So it is nature's way of trying to address the problem. So if your cell-mediated immunity is less, all the mediators which are trying to create your cell-mediated immunity gets deviated towards getting your humoral immunity working. And that causes or worsens your allergic eye disease specifically. So if the idea of telling that was only that in case you have an adult patient who's a new onset VKC-like picture, or you have a child who is significantly recalcitrant and requires repeated episodes of topical and systemic steroid instillation, ask for a history of HIV or any immunosuppressive state, because the immune tolerance of the body is deviated, which can actually worsen your allergic phenomena as such.
Okay, sir. The next is when is systemic therapy indicated for allergic conjunctivitis?
So systemic therapy is indicated when your topical therapy still doesn't work. So if you have a patient with severe VKC and you have given topical prednisolone also, but the patient is still not comfortable, then you are going to be looking at systemic steroid. When you give systemic steroid, the patient obviously will get better because steroids are wonder drugs. But obviously you cannot keep the patient on systemic steroids lifelong or for more than a particular period of time, because they have their own side effects, especially in a pediatric age group. Then you are looking at shifting from systemic steroids to systemic cyclosporine, which is the most commonly used medication as far as allergic eye disease is concerned, or what is published in literature is concerned. To a large extent, with the availability of topical tacrolimus and topical cyclosporine 2%, if the patient is able to tolerate it, the number of patients that we actually need to give systemic steroids has come down significantly. The other group where you would expect to put the patient on systemic steroids or systemic immunosuppression would be the atopic keratoconjunctivitis patients. So when you compare VKC with AKC patients, more likely that we will need to put them on systemic immunosuppression, especially cyclosporine, as compared to a VKC patient. Most of the time, the VKC patients tend to kind of stabilize by around 15 years of age. Even though some of them have recurrences, the severity of the recurrences comes down as they get older.
Okay, sir. The next is, how long can we prescribe low-dose steroids in children?
In desperate situations, we do give steroids low dose, something like lotepred or fluoromethalone once a day or alternate days, making sure that you monitor the intraocular pressure. So these are patients where if I have to continue giving low dose steroids for more than 2 months, then I would seriously consider shifting the patient to a topical immunomodulator like tacrolimus or cyclosporine. So if it's a moderate chronic VKC, I start off with a tapering course of, say, a lotepred, 4, 3, 2, 1 every weekly. We have reduced it. After that, the moment I come down to 1, the patient starts having a discomfort. I might just maintain him at 1 time for maybe another 2 weeks or about a month. Again, try to reduce it at that point of time. But in spite of steroids, the moment we withdraw the steroids, he tends to have a recurrence. Then I would want to put him on an immunomodulator. But once I stop the steroid, if I can have 4 or 5 months of a reasonable quiet period, then again he has an episode. Then maybe again for about a month I can give steroid. For about a month or so, in patients who do not develop glaucoma, who do not develop other complications of steroid, it's not an issue. Again, when you look at potent steroids versus soft steroids like lotepred and FML, the risk of glaucoma or the risk of cataract is much lesser. Having said that, any patient on steroids needs to be monitored for intraocular pressure.
So if a patient is on systemic steroid, then before starting the steroid sparing drugs, how long should we wait for the systemic steroids to work?
Not
safely.
If you're looking at topical, you're talking about topical
systemic.
So generally, immunomodulators will take some time to start their function. So if you have to give a patient systemic medications, we would want to start off topical medication, start on systemic steroids, continue systemic steroids maybe for about a month or so. And at the same time, if after we stop the systemic steroids, he's again worsening, and we've already seen it earlier, and we know that we have to put him on systemic immunosuppression, we would normally start both together at that time. So you start off systemic steroids and keep tapering it. You start systemic immunosuppression. It will take 2 weeks or so for the effect of the cyclosporine to start kicking in to maintain his comfort level. But if he's being put on systemic cyclosporine, he needs to be monitored for his electrolyte levels. He needs to be monitored for his blood pressure and his renal profile, and this needs to be done almost every 2 weekly initially. Ideally, you would want to do a trough level of cyclosporine, but when we are using it occasionally for a VKC kind of a disease, where unlike when we use it for a transplant where the dosage is much higher, we would probably not be doing a trough level because the concentration is not going to be that much that we need to be very worried about the side effects. But we still need to keep monitoring these 3 parameters every month.
Okay, sir. Comparing to loteprednol and FML, which one is better, sir?
probably both are almost the same. There's no study which says this is better or that is better. So it depends on the choice of the person who's prescribing the medication.
Okay, sir. In case of drug-induced toxic conjunctivitis, should we start a topical steroid?
Yeah, if you have a drug-induced conjunctivitis, classically say something with respect to an anti-glaucoma medication, there you will normally find congestion more inferiorly as compared to superior. You will see follicular changes more in the inferior tarsal conjunctiva as compared to superior. So the first thing there would be, this is the drug which is causing it, you need to stop that medication. Depending on how uncomfortable the patient is and how severely affected the ocular surface is, you decide whether you want to give a short course of topical steroids, or you just give lubricating drops and avoid the offending agent. So classically, most of the anti-glaucoma medications will have a toxicity. The worst are the dorzolamide groups and the alpha-GAN groups. So if you can shift them to, say, a beta blocker group, that would be preferable. Even prostaglandin analog doesn't cause follicular changes, but it does cause congestion by the effect of the way it acts itself. So the patient might still be uncomfortable. So if your pressure is such that you cannot stop the medications, then it might actually make sense to stop the medications, put the patient on on systemic acetazolamide for a couple of days, give a short course of topical steroids if the glaucoma is not so bad that we can use steroids for a couple of days, and then plan the patient for a surgical intervention as such, because the moment you're going to be putting the anti-glaucoma medications, they will again end up having a toxicity.
Okay, sir. So the last question in allergic part is how to identify papillae when they are very small clinically.
So basically, when if you look at the papillae, you will actually see a thin vascular core at the center of the papillae. If it's very small, what you can also do is just stain with fluorescein and then look. So fluorescein will always pool around the edges. The central portion will so you will be able to see it much more clearly, because it will be negatively stained with fluorescein. Papillae also will look like that. Follicles will also look like that. But once you are seeing it as negative stain, and then you look at the center of that negative stain, you will be able to pick out the blood vessel which is there. Whereas in a follicle, you will see that the center is pale and you have a blood vessel at the base where your fluorescein is pooling.
Yes, sir. The next is, what is the difference between microsporidial and adenoviral infection? How can we differentiate clinically?
Yeah, so clinically, like I said, you basically, if you're looking at adenovirus, the most common complaint that they will have is congestion, redness, one eye followed by the other eye. Microsporidial, you might have, and adenovirus, almost 90% will have the second eye also involved within a couple of days time. Adenovirus, you will generally have one eye, but you can have both eyes also. Adenovirus, the congestion is going to be much lesser. The SPKs on the cornea are slightly more elevated and stuck on. And the OCT will help you if you don't have the OCT, just the clinical appearance of the SPKs will be there. Generally, most of the time when a patient with microsporidiosis comes to you, he's already been treated for a couple of days and he comes to you and you're seeing the corneal lesions. An adenoviral will come to you when the eye first becomes red immediately, because that is more frightening to the patient to begin with. And the corneal lesions start by the 6th day or the 7th day. Whereas the microsporidial, the corneal lesions will start earlier, because the patient will he will not complain much with redness. He'll probably complain much of photophobia and irritation and a slight haziness in vision. So he will present with corneal lesions, whereas an acute adenoviral conjunctivitis will generally first present with a congestion, and then gradually, as you follow up the patients, you will notice the SPKs in the cornea.
Okay,
the
sir.
final diagnosis would be by scraping it. If you are in doubt about microsporidiosis, the option is to scrape the lesion and examine it under the microscope, and that will be curative also, because you will be able to remove most of the bug, because we don't have anything which is specifically against microsporidial bugs as such. So you have various medications which are there, whether you say a soft steroid, whether fluoroquinolones, voriconazole, multiple drugs have been tried. It generally responds better to just debridement and debulking the corneal epithelium of the bugs.
Okay, sir. The next is clinically how to differentiate between subepithelial infiltrates, scars, and filamentary keratitis or mucous filaments clinically?
Yeah. So mucous filaments will be very easy because once you stain, or even if you look at it and you ask the patient to blink, you can see those filaments moving a little bit. So that is not something which is difficult. When you're looking at between infiltrates and scar, one would be, if you look at the center of those scars, you will normally see some kind of white dots, and around that you will see stromal, very small punctate whitish spots, which basically suggest some kind of activity. It's like cellular infiltration, what we would call from a cornea point of view. So around that lesion, you will see dots which indicate leukocytes which are there. Whereas a scar will normally have a very smooth surface on the epithelium, and you will see there is no staining on the surface. With an infiltrate, you will get a little bit of speck of staining at the center of your lesion, and surrounding the lesion, you will see whitish, very small, fine punctate stromal cellularity, which you will not see in the scar. And again, like I showed you in the OCT, if you have an access to the OCT, that picks up the difference much more clearly.
Okay, sir. How long we need to wait for subepithelial keratitis treated with low-dose topical steroids to shift to tacrolimus?
Yeah, we don't need, see, the thing is, we would normally start the patient, if he has a corneal involvement, we would start the patient on topical steroids, and then we would normally stop it in about 2 weeks time. In a small subset of patients where they tend to get recurrent attacks of the epithelial keratitis, we need to put them on a slightly delayed or a more prolonged usage of the topical steroids and try to stop it. So if the second episode also, when you have given the topical steroids and it is not reducing, I would probably think that I might want to shift over to tacrolimus, because I don't want to have the side effect of steroids. Tacrolimus and cyclosporin both seem to work very well with these recurrent epithelial keratitis in adenovirus, and they are able to, in about 2 to 3 months, we are able to get them off the tacrolimus and the cyclosporin also, and they tend to be fine. Sometimes you will still see clinically minimal activity, but if the patient is not very unhappy and the patient is reasonably comfortable, and we have stopped the steroids, I might just tell the patient, okay, you just continue as long as it's not uncomfortable, just let it go, the body will settle down by itself. You don't need to start you on steroids, because the moment you put the steroid, then you get used to the steroids, so you again want that amount of steroids there. So the treatment of steroids is going to be one, if visually the patient is having a problem, or the quality of vision is such that he's not able to focus clearly, or there's a lot of glare and photophobia there, you have to put the patient on steroids to make him comfortable. And then if it recurs on stopping the steroid, then you look at putting the patient on topical immunomodulators for maybe about 3 months or so, and then gradually stopping all the medications, keeping him only on lubricants as such. If after 6 months or 7 months it still keeps recurring, then the option is to consider doing a PTK, because that will eliminate the abnormal epithelium also. But again, it's not something which is done regularly or routinely. It's a very, very rarely done procedure.
Okay, sir. Coming to last question, what is the treatment for microsporidial keratoconjunctivitis?
That's what I said. There's no specific treatment. The most important treatment is to debride the lesion, and then you can use n number of agents which are supposed to be having some kind of an effect, which could be ciprofloxacin, it could be moxifloxacin, it could be voriconazole, it could be PHMB. All have been tried. There's no single agent which we know is going to work. That's the reason when you have a stromal keratitis with microsporidiosis, to a large extent, the treatment is only with surgery. It's not with medicines. Even though there's one publication from LVP where they have said that they have used a combination of voriconazole and PHMB, and the stromal keratitis has resolved. But the primary treatment for a stromal keratitis is surgery, because medical measures are not so effective against microsporidium.
So one clinical question has just popped up from the hot seaters. Regularly, we see patients with mild congestion and no papillae complaining of burning and watering. So what will be the treatment for them? Is it just lubricants or any other medication should be used?
Yeah. So you need to, if somebody is complaining of burning and watering, you need to know why it is happening. So there you're probably looking at, you're not looking at allergy, because if you don't have papillae and you are not specifically complaining of itching, then allergy is not going to be the first diagnosis. So you're looking at some non-specific inflammation which is happening, which could either be because of a mild dry eye. So then you look at your tear film status, you look at the tear breakup, which could explain. You look at the history where they say how long they look at the systems and things like that. Ask the questions as to when do they have the problem, whether it is early morning or whether it is late. Again, if it is red early in the morning and it happens only in one eye, then you need to look at the laterality, whether he sleeps on one side consistently, which is causing him the problem, whether the lids are floppy, whether there is nocturnal lag of thalamus, which is causing him the problem. So if it's a mild redness but no other signs, you need to go a little bit more into the history to find out what is the reason for the redness, and based on that your decision. But if there's no papillae, there is no follicles, it's only a mild congestion, then you can treat with lubricant drops if you feel there's dryness as such, because there has to be a little bit of dryness or an exposure, otherwise he wouldn't end up with a congestion.
Thank you so much, sir, for answering all the questions so patiently.
Thank you.
Thank you, Bhaskar. Thanks for the wonderful lecture, so much of interaction. Thanks for your time. Thank you so much.
My pleasure. Thank you.
Good night.
Good night.
Good night, sir.
Thank you.